There's a mix. Preterm preeclampsia occurs in around 1/3 of the cases, term preeclampsia around 2/3 of the cases. Preterm preeclampsia is more placental related, and term preeclampsia is more cardiovascular system related, but of course, there's an interchange between these two conditions as any process in medicine. The issue is that we are failing big time to decrease the rate of preeclampsia. We published this major paper a few years ago. That was a study population in Victoria, that Melbourne is the capital when I worked there. We checked 600,000 deliveries over 8 years. The Australian guideline recommending to use maternal history and low-dose aspirin for the ones to be high risk to prevent preterm preeclampsia was published in early 2017. You know that aspirin is very efficient to prevent preterm preeclampsia, but have a look what's the result of this policy using maternal history. Preterm preeclampsia is a completely flat line. Early onset, early preeclampsia is a complete flat line, and term preeclampsia is a complete flat line. Using this strategy, maternal history to try to predict a high-risk group fails. It doesn't work well. When you're talking about preterm preeclampsia, of course, major pregnancy outcomes. Complications are more common in the cases of early preeclampsia and late preterm preeclampsia, especially from the perinatal, but also from the maternal point of view. However, because term preeclampsia is much more frequent, also has a major impact in terms of outcomes. If you look at the influence in maternal outcomes, in adverse maternal outcomes as a whole, the odds ratio is very, very high. It means that even if you're delivering the baby from 37 weeks, preeclampsia, term preeclampsia has a major impact, especially in maternal health. When you're trying to predict preeclampsia, I think that's very classical, and I'm going to show you a little bit that at 12 weeks, at the same time, then the nucleotranslucency scan, we can do a combined algorithm to predict preeclampsia, and it has been very efficient. The problem is when I'm trying to predict term preeclampsia in early pregnancy, we failed because we are so far away from the disease. It means that most likely the best time to predict term preeclampsia is close to disease, close to term, between 35 to 36 weeks. In terms of prediction of preterm preeclampsia, the Fetal Medicine Foundation, since 2009, published a series of papers, large studies, and this one was a head-to-head comparison with the NICE guidelines in the UK, this pre-study. The NICE guidelines uses maternal history to predict preterm preeclampsia, and the detection rate, if I'm using this, is only 41% with 10% false positive. However, if I'm combining maternal history with mean arterial blood pressure, uterine artery Doppler, and one of these two protein markers, PLGF, placental growth factor, or PAPA, and PAPA is the same marker that you're using for first trimester combined screening for Down syndrome. You can see that any combination of these markers is increasing the detection rate of preterm preeclampsia. And the best combination is maternal history, mean arterial blood pressure, uterine artery, and PLGF. And we are able to double the detection rate when we are comparing with history. However, when I'm going to term preeclampsia, the detection rate based on history is only 26%. And even the combined algorithm doesn't improve this detection rate a lot. It means that at this point in time, it's not clinically useful to try to predict term preeclampsia in the first trimester. I'm working in this area for a long time. We are the first group in Australia back in 2013 to introduce the first trimester screening for preeclampsia using the Fetal Medicine Foundation algorithm back in 2013, together with John Hyatt and Andrew McLennan, so are the three pioneer centers in Australia. When I moved to Queensland, that was 3 years and a half ago, we started the third public hospital program in the country that you are offering as a routine first trimester screening for preterm preeclampsia together with the first trimester ultrasound. And this is funded by the Australian Medicare system. Finally, the Australian College of Obstetrics and Gynecology, the RANSCOG, aligning with the international guidelines that were published by IJOG and FIGO back in 2019. In April 2024, a few months ago, this task force, and I was privileged to be part of it, changed the 2015 guideline in Australia that was basically in the past recommending maternal history. Nowadays, we are recommending that we have to offer early screening for preeclampsia for every pregnant woman in Australia. And the best way to do that is using the multifactorial screening. And of course, if a patient is deemed to be high risk, there's formal recommendation to prescribe at least 100 milligrams of aspirin. The ideal dose is 150 milligrams before 16 weeks up to 36 weeks of pregnancy. When I'm doing that, we don't know very well what's the mechanism that aspirin prevents preeclampsia. But basically, the result of it is I'm eliminating some cases of preeclampsia, but I'm pushing some cases of preterm preeclampsia to term preeclampsia. It's another reason that's so important to try to predict term preeclampsia, even if I have a program that I'm doing first trimester screening and prevention of preterm preeclampsia. We, as I mentioned before, we had these three pioneer centers and that you are doing screening since 2013. In clinical practice, it's more than 100 sonographers and maternal, fetal, and ultrasounds and subspecialists doing that. And a couple of years ago, we put our numbers together. From 2013, when we started up to 2017, this was just before the publication of the ASPRI trial, we screened nearly 30,000 patients using the combined approach. We compared with 300,000 patients that didn't have the screening. At that time, because it was before the ASPRI study, we were suggesting the clinicians to prescribe low-dose aspirin. At this point in time, after the ASPRI publication, we are recommending low-dose aspirin and we are prescribing and we are doing the screening. But even at that time with the suggestion, we can see that for preterm preeclampsia, using the multifactorial screening and prescribing low-dose aspirin, we are able to reduce the rate of preterm preeclampsia in 30% of the cases. It was a very positive surprise. We know that aspirin doesn't work well to prevent term preeclampsia. However, when you check at all preeclampsias, we had a reduction of 31% of the cases. Very likely, and I'm going to talk a little bit more about that, time in the delivery around 39 weeks in patients that didn't develop preterm preeclampsia, but they are high risk for it. If I'm delivering these patients around 39 weeks, I can prevent around 30% of the cases of term preeclampsia as well. Let's go to the main topic of my presentation. That's third trimester prediction and prevention of term preeclampsia. I have in my hospital university a quite strong lab group that we are working for years to try to identify novel biomarkers to predict preterm and now term preeclampsia. And one of our PhD students, her name is Luhao Han, she's from China and she's working with us for 3 years now, is doing her PhD to try to find novel biomarkers for term preeclampsia. But the first part of her project was to check the literature, and we published this review. When you check the proportion of different trimesters that was published to try to predict term preeclampsia, we still can see that the majority of studies are done in the first trimester. Unfortunately, the results are not very good because, as I showed you, it's too far away from the disease, and prediction at this time is not great. At this point in time, we don't have randomized clinical trials about that. There's a trial that's going to be published very soon. That will be the first randomized clinical trial trying to predict and prevent term preeclampsia. In terms of algorithms, there's a mix of algorithms and competing risk model that was the similar model that was used for first trimester screening, was performing around 40% of the cases. But you can see here very clearly in this chart that the detection rate for term preeclampsia increases along the pregnancy, and the best time to do that is around 35 to 36 weeks. And this that we have to concentrate our efforts. As part of the Nature review, we show that it's quite well established, the first trimester screening for preeclampsia. We can try to do that at 20 weeks, at 32 weeks, but the best time is between 35 to 36, 37 weeks. And also I can use a combination using maternal history, blood pressure, S-FLEET PLGF that I'm going to show you how you can do that at this point in time. In terms of placental biomarkers for preeclampsia, I mentioned before that PLGF and PAPE are the ones that you can use in the first trimester. S-FLEET is not a first trimester marker. S-FLEET is a marker from the second half of the pregnancy, at least from 20 weeks, but works better from 24 weeks onwards. In the second and third trimester, I can use S-FLEET PLGF ratio. S-FLEET is also a placental protein that's increased in patients that are going to develop preeclampsia and also is associated with the diagnosis of the disease. I can use this as a tool to rule in or rule out preeclampsia when I have a suspicion of that. But I also can use these two biomarkers in the second half of the pregnancy to predict term preeclampsia. Just coming back, the original paper that showed how is the profile of S-FLEET and PLGF during the pregnancy. This was published by Levine back in 2004. You can see in black, there are the controls, the normal pregnancies, and in red, the pregnant women that they develop preeclampsia. You can see that S-FLEET clearly is not a first trimester marker, it's not a marker in the first half of the pregnancy because there is no difference between the groups. From 20 weeks, but especially from 24, you can see that there's a significant difference when you compare someone that is having a normal pregnancy and someone that's developing a preeclampsia. PLGF, in the other way, is a first trimester marker. At the time of the nucleotranslucent scan, there's a difference between controls and patients that are going to develop preterm preeclampsia. And of course, along the pregnancy, this difference is quite marked as well. This is the reason that they are the best markers that you have at this point in time for prediction of preterm, but also term preeclampsia. There's a classical trial that was published in 2016. Stefan Verlohen from Berlin was the senior author of this study that's called prognosis study. Basically, in patients with suspicions of preeclampsia presenting with gestational hypertension, if I measure in the second half of the pregnancy S-FLEET PLGF ratio, if the ratio is above 8.5, I can make the diagnosis of preeclampsia. And the sensitivity of that is 85% with 84% specificity. That's a good test if I'm doing to help in the aid of diagnosis of preeclampsia. The question is if I can use the ratio as well as to predict and also to check the prognosis of preeclampsia. This paper was published by a large American group. And of course, all of us, we are still using the organ targets of preeclampsia to check, to make the diagnosis of preeclampsia and also to make the diagnosis of HELLP syndrome. The question is, if I'm using this classical liver, renal, platelets, biomarkers, if I can predict prognosis. And you can see when I'm comparing in this ROC curve, S-FLT-PLGF ratio is a much, much better test than any of these routine tests that you do to predict the severity of preeclampsia, to predict severe preeclampsia. If I'm using a multifactorial combination in a similar way than in the first trimester, but at this time using maternal history, PLGF, and S-FLT, it's possible to predict around 75 to 79% of the cases of preeclampsia between 35 to 37 weeks. We decided, because of all of this, together with Sailesh Kumar, that's a colleague from Brisbane, from the University of Queensland, we have a cohort of patients with fetal growth restriction, and around 70% of the cases of fetal growth restriction, they are related with preeclampsia. In this cohort of more than 200 cases of fetal growth restriction, we tested every 4 weeks in the second half of the pregnancy S-FLT and PLGF. You can see here that in the different subtypes, in the different phenotypes of fetal growth restriction, there's a major correlation between low PLGF, that's level below 100, with time of delivery. In blue are the fetal growth restriction cases where the PLGF was over 100. In red was below 100, and there's a major correlation with timing of birth. For our surprise, also in fetuses that they have normal weights, they are adequate for gestational age, there's a correlation between the level of PLGF and also the S-FLT-PLGF ratio in terms of time of delivery. I can use this tool, I can use PLGF or S-FLT-PLGF ratio to try to predict time of birth, and this seems quite efficient. Of course, because you are doing Dopplers as a routine in case of fetal growth restriction, we published another paper quite recently that we combine PLGF and S-FLT-PLGF ratio with the classical Dopplers that we do. And you can see again in this proportional hazards regression model in time of the diagnosis and time of delivery in days. In yellow are the cases that the time of delivery was much, much shorter. And these are the cases where PLGF was abnormal, below 100, but also uterine artery Doppler and uterine artery Doppler, they are abnormal. There's a major correlation using fetal Dopplers also with PLGF or S-FLT-PLGF ratio. And the combination is the best way to predict timing of birth. The other thing that I'm just going to mention, because this is probably coming in the new version of the Fetal Medicine Foundation software that's about to be launched, I can use ophthalmic artery Doppler in the 3rd trimester of the pregnancy to predict preeclampsia. We published some years ago this opinion at the White Journal summarizing the literature. Just for you to understand, to do ophthalmic artery Doppler, actually the technique is very, very simple. You use a linear probe, same probe that you're using for thyroid scan or for breast scan. The pregnant woman close the eyes, we put a drop of gel in the eyelids. You can see the ocular globe. You can see hypoechogenic line, that's the optic nerve. And if I'm putting my Doppler sample there, there's only one big vessel crossing above the optic nerve to the midline, and this is the ophthalmic artery. It's so easy to identify. And it has this pattern of waveform that's a dichrotic wave. There's 2 systolic peaks. This is called P1, that's the first systolic peak, and this is called P2, that's the second systolic peak. And a series of papers originally from Japan, but also a large number of papers from Brazil, including from my group, showed that ophthalmic artery Doppler is correlated with preeclampsia, but also it's possible to predict preeclampsia since the 1st trimester of pregnancy. And this is coming for clinical practice right now. Just to show you one example, this is a normal waveform where P1 is much higher than P2. And this is a case of severe preeclampsia that there's an increase in the velocity of the P2, and this is abnormal ophthalmic artery Doppler ratio, extremely related with preeclampsia and the severity of preeclampsia. We can use ophthalmic artery with the similar detection rate than a slit PLGF. It means that if I don't have a slit PLGF available in my hospital, I can use ophthalmic artery Doppler as part of the algorithm to predict term preeclampsia with a good performance. There is the Fetal Medicine Foundation algorithm to predict term preeclampsia in late pregnancy. Yep. This needs external validation. We are conducting
you're muted now, Fabricio. Fabricio, can you hear me? I think you just, I don't know what happened. You just got muted. Yeah. So I think you were just talking about the validation. So it's not been validated yet. I think you were just saying that you're validating it now.
Yeah. Could you hear me now? Yeah. Okay. Sorry. I'm just going to repeat. I don't know when I was muted. Basically, the Fetal Medicine Foundation has an algorithm to predict term preeclampsia using maternal history, using blood pressure, uterine artery Doppler, and a slit PLGF ratio. This needs external validation. The first trimester algorithm was quite well validated. This one needs external validation. You're conducting my center a validation at this point in time, and other centers around the world, I believe that they're doing the same. And then comes the thing. If I can predict term preeclampsia, I have to find a way to prevent term preeclampsia. And this is a very nice review that was published in the New England Journal. If you have low-dose aspirin to prevent preterm preeclampsia, what can you use at this point in time to prevent term preeclampsia? Unfortunately, metformin, statin, and other therapies, they fail to do that. The only one at this point in time that works is timely delivery. If I have a truly high-risk group, if I'm delivering these patients around 39 weeks, very likely I can reduce term preeclampsia in around 30 to 35% of the cases. And as I mentioned before, there's a randomized clinical trial that will be published very soon, going to confirm that. There are some studies that try to do this combined approach and compare with the NICE guidelines using history. Using the Fetal Medicine Foundation algorithm for preterm preeclampsia compared to the NICE that's using history, you can see that I have to induce a larger number of patients in different gestational ages to prevent not a very big group of term preeclampsia if I'm using history only. If I'm using the 35, 36 weeks competing risk model, the number of patients that I have to induce in different gestational ages, if I can stratify in terms of risk, is much, much lower, and the effect is much, much higher in terms of prevention of term preeclampsia. The issue, and I think that's a particular issue for clinical implementation, that this is a bit complex. If I have different cutoffs and different gestational ages to delivery, maybe if I'm using one simple cutoff, 1 in 50, and then if I'm delivering these patients at 39 weeks, is a much, much more pragmatic approach that's going to give us the 30% effect in terms of prevention of term preeclampsia. The protocol of the randomized clinical trial that I mentioned was published in October. That was a very, very short time ago. That's basically using the 35 to 36 weeks algorithm to predict preeclampsia. If the risk is higher than 1 in 50, these patients will be delivered at 39 weeks. We are all looking forward to see this study published. This was presented by the first time a couple of months ago in our EJOG Congress in Budapest, and basically they are going to show 30% reduction of term preeclampsia using this approach. There's another study that the protocol was published a short time ago, coming from Barcelona's group. they're going to use a split PLGF ratio at 35 to 37 weeks to try to predict a high-risk group for a term preeclampsia. They are going to do a randomized clinical trial, and they are going to deliver the patients from 37 weeks if the ratio is abnormal. One concern that I have that the cutoffs that they are going to use is only 25 at 35 weeks and 35 at 36 weeks. I'm working in this area for a long time. Unfortunately, this cutoff, that's the 90th centile for their population, I believe that's a little bit lower. They're having a very high number of screen positive patients. I think that we need to wait for the results of this trial. Of course, it's well designed, and to see if the screen positive rate is not too high, and to see what will be the performance of this approach in terms of reduction in the rate of term preeclampsia. I hope that in a couple of years this paper will be available for us. But I like to show you this. This is a quite interesting chart in Australia, in New South Wales, basically showing the big move in terms of gestational age of delivery. I'm going to show you that again, because since 2000, there's a major shift in the gestational age of delivery. And after the publication of the ARRIVE trial, this shift was very consolidated. We are delivering more patients at 39 weeks. However, doing this approach in terms of general population is not decreasing the rate of term preeclampsia, because the rationale is the same that when I'm using aspirin. If I'm prescribing aspirin for the totality of my population, I'm not preventing preterm preeclampsia. If I'm delivering all my patients at 39 weeks, this won't be very efficient to prevent term preeclampsia, and eventually I can have some harm, and I'm not following the desire of a large number of our population because they want to have a chance to have a spontaneous onset of labor. If I have a test that I can predict a truly high-risk group for term preeclampsia, and then for these patients, I'm using timely delivery, I believe that's the best approach. The other point, and there's a movement in Australia, is the issue of early term delivery without a medical indication. The fetal brain matures actually quite a lot from 37 to 39 to 40 weeks. There are major changes, and it can have some impacts in learning difficulties at school entry if I have, of course, preterm birth, but also if I'm having early term deliveries. It means to deliver someone in this gestational age, I have to have a clear medical indication to do that. I think that's the big challenge for all of us, is how you can introduce is a little bit sophisticated approach, but it's possible to be done for the total of our pregnant population in the different parts of the globe. And I think that's the discussion that you're going to have at the end of the presentation is going to help us, and it would be nice to hear your perspective about it. Just finalizing, Asma, my presentation, we are conducting two major studies here in Australia. One is to find novel biomarkers for preterm and term preeclampsia in different gestational ages. This is called the Placenta Health Study, that you're collecting a series of maternal and fetal biophysical and biochemical markers and putting all together to validate known algorithms, but also to improve or to create new algorithms for that. The other study that you're going to start, we just got a major grant to do that, is the implementation of these algorithms in 8 large maternities in Australia that you're doing. You're going to do first trimester screening, you're going to do screening at 20 weeks, and we also are going to do screening at 36 weeks, and using the interventions in order to try to improve maternal and perinatal outcomes. These are the 8 maternities that will be involved in this study. They're the large 8 maternities in the country, and they comprehend around 45,000 deliveries per year. We're going to start the clinical implementation of it, hopefully by the end of the next year. Finalizing, I think that's very clear that first trimester screening and prevention of preterm preeclampsia with aspirin is quite well established. The challenge is implementation in the different parts of the world and different health settings. If I'm going to term preeclampsia, unlikely in preterm preeclampsia, prediction and prevention of preeclampsia is still unresolved. I think that we have some important trials that are coming out very soon. They're going to help us with that, but definitely we are some steps back when you compare with preterm preeclampsia. Prevention of term preeclampsia at this stage is delivery. We don't have a drug that can do that. And of course, we need some research. There are some things coming from the industry. One example is a drug, is a siRNA drug that basically can knock out the gene for S-split. There are a phase 1 study going to start next year. And hopefully we are having a drug that can help in this regard, but it's not available at this point in time. But we have quite exciting future research that, as I mentioned, is coming out very soon. I believe that the next 2 to 3 years are going to have some things quite interesting in regarding of term preeclampsia. This is my team. This is my clinical fetal medicine team. This is my clinical research team here from the Gold Coast and my lab team. And we are privileged to live in Queensland, in Australia. That's this beautiful place. This is my hospital complex. This is Griffith University. If you like Olympics, half of the swimming team from Australia, they train in this pool. If my university is a country, you are supposed to be the number 11 in the medals ranking from the last Olympics because of the Australian swimmers that they train here. It's a nice place to live. Definitely, it's a nice place to work. Thanks so much.
That was wonderful. Thank you so much, Fabrizio, for a really comprehensive talk covering, all sort of the, not just the, the recent updates and the evidence, but also some of the challenges of implementing and, whether to induce all women early to avoid preeclampsia or prevent preeclampsia. So fantastic talk, really, really beautiful. Thank you very much. And huge amount of work. So well done and congratulations to you and your team. I love the picture about the Gold Coast, but do you have many shark bites there?
Not a lot, just some.
Okay, brilliant. Thank you very much. I think what I'm going to do is that, because I think it's still the questions are coming, and from my experience, people still take time to type their questions. So I think what we're going to do is we're going to go ahead with the next talk by Shahenda, and then we will have maybe questions after that. So if that's okay with you, Fabrizio, to stay with us, that would be great.
Yeah, yes, of course, it'll be a pleasure.
Lovely, great. So my next speaker, Dr. Shahenda Hossein Doha, and as I mentioned and introduced her earlier, she's a cardiologist. She's not really obstetrician, but I'm sure she has extensive experience dealing with pregnant women. And she's going, the title of her talk is Cardiovascular Changes During and After Preeclampsia. Thank you, Shan.
Well, thanks a lot, Esma. I'm trying to share my presentation here. Thanks a lot, Esma. And I also join your compliments to Fabrizio. Really a great talk, which I enjoyed listening to. And thanks a lot for the invitation. And I'm happy to share